Good afternoon, everyone. I will be presenting on a novel decision tree with biomechanics and refractive surgery, and I have no financial disclosures. So the evolution of diagnostic modalities in refractive surgery has been a boon in picking the right choice and avoiding complications. Currently, the decision is majorly dependent on the basis of corneal tomography and biomechanics. So here are a few case scenarios in our refractive clinic. The first one showing a normal topography and a normal biomechanics, an ideal case to go ahead with refractive surgery, and the second one showing keratoconus, which is an absolute contraindication. Here are a few more case scenarios that may present to us. The first one with a normal tomography, but an abnormal biomechanics and abnormal TBI, and the second one with a normal topography, borderline bad D, normal biomechanics and abnormal TBI. What do we do in such case scenarios, and how do we proceed further? So which parameter should we give more weightage to? Should it be a corneal topography, which is an indirect measurement of corneal structure, or biomechanics, which is an indirect measurement of strength? We stumbled upon an article which studied the role of biomechanics for evaluation of ectasia in patients, and we found that TBI had showed a better performance with all the other individual parameters, in concluding that integration of biomechanics with tomography augments accuracy for detecting ectatic disease. And biomechanics is an essential tool in this screening process. We lacked a systemic approach in the existing literature to plan the refractive surgeries in various case scenarios. So this brought us to our research question of how do we make this confusion matrix more understandable to the clinicians. So the purpose of our study was to plan an algorithmic approach to plan refractive surgeries on the basis of tomography and biomechanics, and to optimize visual tomographic biomechanical outcomes after the surgery. We carried out a study where we recruited 345 eyes of 175 patients. After the ethics committee approval, informed consent was obtained. Patients motivated for surgery with no corneal scarring, ACD more than 2.8 and RSB more than 270 were included. The ones with active ocular surface allergy, corneal scarring, pregnancy, lactating mothers and prior ocular surgery were excluded. It was a prospective interventional study where extensive clinical evaluation with diagnostics was performed. Patients were categorized into 4 groups, and then the refractive surgery was planned accordingly. They were evaluated at 1, 3, 6 months post-operatively, 1 year and 3 years post-operatively. So the 4 groups into which they were divided were: the first one having a normal tomography and biomechanics included 100 eyes, the second one with a normal tomography and bad D, a borderline biomechanics and CBI, and a borderline TBI, the third one having 80 eyes with borderline topography and bad D, normal biomechanics and CBI, and a borderline TBI, and the third one having all the indices abnormal included 65 eyes. Now applying the algorithm in our clinics, the first group was planned for LASIK, SMILE or PRK depending upon the examination, diagnostic reports, patients and the surgeon's preference. The second one, we further checked the parameters like biomechanical corrected IOP, stiffness parameter and the scan quality. The ones with a normal BIOP or along with stiffness parameter less than 100 were planned for phakic IOL. The ones with normal BIOP and stiffness parameter more than 100 were planned for SMILE extra or PRK. The ones with a low BIOP and low SPA1 and good scan quality were planned either for a phakic IOL or PRK depending upon the spherical equivalent. The poor scan quality patients were re-evaluated and then planned. The patients with having a borderline topography with normal biomechanics, a good quality scan, the epithelium was checked. The one with normal epithelium were planned either for a phakic IOL or trans-PRK. The ones with abnormal epithelium were treated for ocular surface inflammation, as the borderline bad D was considered was correlated with this abnormal epithelium, and then were planned for LASIK or SMILE after 6 months. The ones with poor scan quality and abnormal angle kappa were re-evaluated and then planned for the surgery. Those patients with an abnormal topography and abnormal biomechanics were planned for phakic IOL implantation. So this graph shows the distribution of patients undergoing the type of refractive surgery in each group, and this is the efficacy where the post-operative uncorrected visual acuity was more than 20/25 in 98% of the patients in group 1, 99 in group 2, 96 in group 3 and 95 in group 4. There was no loss of lines in group 2, 3 and 4, and 1% of patients showed loss of 1 line in group 1. One case out of 345 eyes developed ectasia after 3 years. So our algorithm is safe and effective in all 4 groups. The algorithm is accurate in classification of patients according to their tomography and biomechanical characteristics, and is in accordance with the previous literature where CBI and TBI showed good correlation to the predictive postoperative outcome. It is prudent to avoid SMILE and LASIK in suspect eyes and better to go for extra procedures. The patient that developed ectasia had a normal tomography and biomechanics. Lenticular analysis showed decreased expression of LOX and collagen, and this decreased pre-existing levels of LOX and collagen may predispose clinically healthy eyes undergoing refractive surgery to develop ectasia post-operatively. So pre-op molecular testing may reveal ectasia susceptibility in absence of tomographic and biomechanical risk factors. So what was known is corneal biomechanics is an important tool for pre-op assessment, and it is relevant for a proper follow-up of post-laser vision correction patients. It helps in early diagnosis of patients with high risk to develop iatrogenic ectasia. What the study adds is, it is the first study that proves efficacy and safety of an effective and simple algorithmic approach to plan refractive surgery. It augments accuracy for integration of biomechanics and tomography, augments the accuracy to detect ectasia and also identify susceptibility to ectasia. Addition of CBI and TBI in the algorithm makes it more robust in diagnosis of suspicious cases.